This is a case of a 42-year-old woman who was in her usual state of good health until about 3 months ago when she noticed a small lump on her right breast while bathing. She noted that the lump was painless, it was mobile, it didn't have any warmth or redness, and it had grown a little bit over the past few weeks. She hadn't noticed any changes in the size of the mass in association with her menstrual cycle. On physical exam, the main finding was that she had a 2 by 3 centimeter movable firm mass in the right upper quadrant with surrounding dimpling of the skin and no nipple retraction. Her labs were all within normal limits. On imaging, she had a diagnostic mammogram that showed a spiculated mass in the right upper outer quadrant, and on ultrasound, she had an echo-complex mass with calcifications, and it was spiculated, and it was 2.6 by 1.7 by 1.9 centimeters. And this is a picture of the mass on the diagnostic mammogram and on the magnification views here. So we'll stop at this point. This is what we know about this patient, and we'll ask Dr. John Scheel, our radiologist specializing in breast imaging, to discuss radiology and breast imaging in this setting.
So after our discussions yesterday, we decided to change our talks a little bit to make it a little bit more applicable to the situations that you guys find yourselves in. So the talk that I'll be giving is standardized an approach to women presenting with a palpable lump, which is typically how we see women presenting in Africa. So according to the World Health Organization, the goal is downstaging if there's no active screening program. And the reason for it is that early stage breast cancer, stage 1 or 2, the survival with access to treatment is about 80% versus 40 to 50% if it is detected in the later stages. So the idea is that even with small interventions to downstage breast cancer can have a dramatic impact on mortality. So you can think of early detection through 2 methods, and that's early diagnosis or screening. And screening really isn't an option for population. I mean, in order to have an impact on population, you really need to have about 60 to 70% of the population screened. So it's really about getting the diagnosis early, and that requires being out in the community and talking to the women, increasing awareness. But before you do all that, before you flood those women into the limited resources in the clinic has to be prepared for evaluating these women in an efficient manner. So we call this the triple test, which is clinical breast exam, diagnostic, mammography, and ultrasound. And we use these 3 methods simultaneously to evaluate women with palpable lumps. And then I'll briefly show a percutaneous biopsy, which is the next step. So starting with clinical breast exam, it's widely available, cheap to deploy throughout the world, and it can be accessible to women who live in rural communities, which is 80% of the African population. However, there's a potential for false positives, up to 80% in some studies. So you can imagine that if you're doing a breast exam and you're saying 80% of the time you do it, you're finding a lump that needs to be evaluated, you're going to have a serious problem with making this a cost-effective or sustainable test. There are a couple of things that can limit the clinical breast exam. One is patient factors, so if they have really dense breasts, doing a clinical breast exam is challenging. But most of the variability comes from practitioners. So a practitioner experience, for example, can attribute 90% of the variability, and using a standardized approach to performing the clinical breast exam has about a 20 to 30% improvement in their performance. So currently, women with a positive clinical breast exam out in the rural communities get referred to the referral hospital, and they require biopsies or further evaluation. Oops. So one of the studies that was published this month used an algorithm that used ultrasound, inserted it at the community level, and said, can we triage these women so that not all of those women with a positive clinical breast exam need to travel the long distance to the referral center to get evaluated? And so they trained these sonographers already practicing imaging and trained them to perform breast imaging as one of their skill sets. And then all women who presented got examined by a clinical breast exam, and those with the clinical breast exam that was positive were evaluated by breast ultrasound. And only the ones that had a positive mass that needed evaluation were then sent to the referral center. And this was done by Imaging the World. So with this project in Uganda, they actually did some community outreach. They screened 212 women that had a self-detected lump and presented to the center, and 44% had a positive clinical breast exam. And now these 44 women would then go to the referral center, but then they inserted ultrasound and reduced that to 11 women. So 1/4 were left, and those women went on to get a biopsy, and only 4 underwent a biopsy. So obviously one of the problems is that 7 women opted not to get a biopsy despite having a suspicious mass. And 2 of those 4 women who got a biopsy were diagnosed with early stage breast cancer and the other 2 women had late stage breast cancer and ended up dying. Now this is a very small sample, but it gives you the option of looking at this and saying, okay, historically 89% of women in Uganda from these rural communities present with late-stage disease, and with a small intervention that was shifted to 50%. And those 50% ended up having lumpectomies, radiation, and completed treatment, and were able to return to their families. 75% with these palpable lumps did not need a biopsy or a referral. They were just able just to come in, be evaluated with clinical breast exam and ultrasound, and then continue on their daily activities. So diagnostic ultrasound, there are several causes of benign or normal findings that are evident on clinical breast exam that the ultrasound can readily identify as being normal or benign. So this is normal breast tissue, and you can imagine when you do a breast exam and you're coming across this ridge of breast tissue and then it sinks down here, that can feel like a normal breast, that can feel like a lump or a mass because it has that rounded edges, but in fact on ultrasound you can clearly see it is normal breast tissue. And just to orientate you, this is the skin, this is the chest wall, the white areas of breast tissue. Similarly, a rib, which looks like a scary mass except for you notice that it's abutting the pleura, that can also present as a palpable abnormality, and on ultrasound you can clearly see that it's a rib and you can let the patient go. Here, using landmarks, you can see that there's a rib, but there's also a mass, and this mass has the muscle on top, so you know that it's actually in the breast and needs to be evaluated. Here's a simple cyst, another common finding in young women in particular. It has very characteristic appearance, and this is benign, and this doesn't need to be biopsied. This, however, is a scary mass. This is one that you wouldn't want to take home to your parents. This has spiculations here, and it's hypoechoic. It's an irregular mass. And so this is something that you would want to biopsy. This is someone that you would want to spend the resources to get to the referral hospital to have evaluated. This is almost certainly cancer, greater than 95%, and you can tell that all based on the imaging. So tissue sampling techniques is percutaneous ultrasound-guided biopsy. So this is the biopsy device that's coming. You can see a nice straight echogenic line going towards this mass. There's the mass right there. I'm not sure if you can see it. There's the trajectory. And there, the echogenic line now extends past the mass. So this mass has been biopsied. And of course, as we've talked about, getting the sample into some fixative is essential for good pathologic diagnosis. So mammography, one of the limitations is that, and I'm going to show you a couple of these limitations later on, but dense breast, the white stuff is the breast density, and you can imagine trying to find a cancer in there, which also appears white, is going to be very challenging. So it's not just about getting the mammography machine, it's also about the person interpreting it, the patient factors such as how they have dense breasts. but it has some advantages. So that mass that I showed you on the previous screen that had that mass next to the rib, we would biopsy that if we did not have a mammogram. But here we see a nice fat-containing mass that is classically benign. It's an oil cyst. It's caused by trauma, and we don't need to biopsy it now. So they provide complementary information. Here is the case that that Dr. Graylow just went over. You can see that it has spiculated margins, and it's irregularly shaped. This would be something highly concerning, greater than 95% chance of malignancy. And that's the mass there. So ultrasound is fairly straightforward to implement into a system because it requires very little input from technical staff. Mammography is very different. So with mammography, the problem is that you have to have a way to communicate and benchmarks to follow, so you can't just call back every single thing you see on a mammogram as being abnormal, otherwise you're not adding value. So we also need technical staff to perform the mammogram, and you need proper equipment. So we use the BI-RAD system, which is a breast imaging reporting and data system, and that has been shown to improve medical tracking and also making accurate assessments. And it's something that was developed by the American College of Radiology and is used worldwide. In fact, I imagine that most of your institutions use some form of this standardized reporting system because it's been very successful. So, unlike other parts of radiology, we have a very limited set of terms that we use, and those terms determine the management. It's driven by an algorithm, and that handles greater than 85% of our cases. Here's a kind of abbreviated BI-RADS form that we use in Uganda, where you can see that you only have 2 choices, and if you choose anything at the bottom, the patient's going to end up getting a biopsy. So the final thing that I wanted to go over is it's more than just a mammogram, it's a reading room environment. So this is a reading room, and as you can see, there's a lot of light here, and here you can see that the light box for reading the mammograms is too small for the mammography film, so they just kind of fold them up. That's not optimal, and you're going to be missing a lot of things by reading this way. The alternative is to read it off of a low luminescence, so these screens are not bright enough, and there's a lot of light leaking around. This would not be an optimal reading room environment. This is our reading room environment. You might not be able to tell that this is somebody here reading, and the room is completely black, and this is by law. It has to be nothing more than a certain amount of brightness. Here's our light board, so we can read film screens as well. And you can see that it has shutters to completely block out the light surrounding the mammograms. And the idea is you don't want your eyes to be blinded by the light and not being able to see subtle tissue distortions that are present in the mammogram that might indicate that there's a problem. That's it.